is an assistant professor at Emory University since 2019, specializes in Gait biomechanics, recently awarded KO1 by the NIH for research focusing on biomechanical aspects of gait and diabetic patients, and particularly those with diabetic peripheral neuropathy. The aim for this study is to develop non-invasive gait retraining methods to enhance walking functionality of quality of life and reducing complications, particularly ulcerations. So looking forward to your talk today.
Thank you, Maya. So as Maya introduced me, I am Dr. Nicole Rendos. And before we actually get started with the talk, I wanted to give you kind of a little bit of what was my impetus for going into this field. So I actually came from a background of running and sports biomechanics. And my husband is a foot and ankle surgeon. And at the time, he was a first-year resident. And he was doing multiple, like sometimes 10 to 20 diabetic amputations a week. And he came home, and one simple question I asked him at dinner one night is, well, you just cut off half of somebody's foot. What do you do with that? And really the standard of care for a top 5 medical system in the country was to stitch them up, send them home, and see if they heal. There was really no impetus for sending them to rehab after you cut off part of somebody's foot for diabetic amputation. And that really differed from what you would see from like a traumatic type amputation, like an accident or somebody who was in the military. That standard of care was really different. So that was really that one simple little question, what spearheaded my entire trajectory into this field of research is, why don't these people get the same type of care that somebody with a traumatic amputation would get? And then it went further into how can I potentially prevent these amputations from occurring into the first place? So that was really my entire impetus for getting into this field of research, coming from a gait background. So I understood walking, I understood running, but why was the care not the same given to those individuals? So diabetic peripheral neuropathy, again, I started with the amputation question, but the amputations really stem from the diabetic peripheral neuropathy to begin with. It's the most common complication. About 50% of those people diagnosed with diabetes will eventually develop diabetic neuropathy as well. So we're going to see about half of those 38.4 million people develop diabetic neuropathy over the course of their disease. And what that causes is it causes them to reduce sensation and feedback from the lower limbs. So they tend to, as it gets worse, they can't feel the bottoms of their feet. And they don't have that same proprioceptive feedback coming from the feet and the lower limbs up to the spinal cord, up to the brain, to allow them to walk properly. So now I can't feel my feet, I can't walk properly, and I'm also losing muscle strength because there's a motor neuropathy component to it. So I have a sensory neuropathy, I have a motor neuropathy component. So now I'm not only not able to feel the ground, but I'm losing strength in those muscles that actually cause or contribute to walking. And we know it is one of the most significant risk factors for diabetic foot disease. It leads to often ulceration and amputation. So this is a study I published with that surgeon husband we actually looked at index toe amputations. So we looked at individuals who had a toe amputation and then followed them out for a series of years. I believe it was a 5-year period in the Pittsburgh medical system, so UPMC medical system, and found how often did they re-ulcerate. So how many new wounds, new ulcers did they develop? How many times were they admitted for a re-amputation, and how many times they were admitted for a re-operation of sorts in terms of, was it something to wash out an ulcer? Was it something to repair? And we noticed that those people with diabetic neuropathy had significantly more complications or new development of new wounds, new operations than our non-diabetic cohort. And not only did they receive more amputations, is those amputations tended to end up going further. So they went further up the limb really ending in a below knee amputation, whereas if you follow the other cohort, the average amputation level that you would see may have been another toe or potentially transmetatarsal amputation, but not losing part of the leg. So we want to get to a point where can we kind of add a preventative effect of this so they don't get to this ulceration and the amputation risk. And then we know that the most recent estimates is that diabetic neuropathy is a significant part of the healthcare budget, so 128 billion. The 2017 estimates for the total amount of economic burden of diabetes was 227 million, or 227 billion. So we're looking at more than half of the 2017 estimates just for the neuropathy complications alone. So again, how can we now put a pin in this to hopefully stop somebody from that ulceration, the amputation piece, and then also help them with their quality of life? So their quality of life with the diabetic neuropathy, they have increased pain, increased discomfort, they have problems with mobility and activities of daily living. And specifically what I'm interested in is those walking impairments, because if you cannot walk from your house to your car to the grocery store, around the grocery store with functional mobility, you really lose that quality of life that many people need. So they have reduced functional ambulation. It may be very hard for them to get out of their house, into a car, into a grocery store. Reduced walking speed, so they walk much slower, and reduced step counts, so they walk less throughout the day. And then specifically, the two pieces that I am really interested in is a reduced propulsion, so being able to push off the ground, and an increased plantar pressure at the bottom of the foot. So this reduced propulsion means they can't really walk effectively. They're losing their ability to push off, which leads to that reduced functional ambulation. And they also have increased plantar pressures. If we see too high of an increase in this plantar pressure, then we can potentially see ulceration of the bottom of the foot leading to amputations. So they might be two factors that very significantly relate to that substantial reduction in quality of life. And so this is the diagram I created with those two specific factors that I term the cycle of disability. So we have our DPN individuals, they have increased plantar pressure, decreased propulsion, which are both parts of gait dysfunction, but the increased plantar pressure increases their risk of ulceration. The decreased propulsion then reduces their gait speed and mobility, so it gets them into a cycle of disability. So often, with especially type 2 diabetes, we see it being a result of decreased activity levels, decreased physical activity, and when you see that, they may be diagnosed with diabetes, and then as they have an increased disability from the diabetes, they have reduced quality of life. They don't want to walk again because now they have an increased disability, and it just continuously makes it into a negative feedback cycle, making that worse. So is there a point where I can say, here's something I can target non-pharmacologically that I can put an intervention in to stop that negative feedback cycle? So currently, what we see is treatments for diabetic neuropathy. Of course, the first thing we want to manage is glycemic control. And glycemic control is a large realm of management, and it relates to everything from pharmacological interventions, diet and exercise recommendations. What we do see is a lack of rehabilitation interventions as well. And then on top of our very commonly recommended pharmacological interventions, most physicians will say, hey, make sure you exercise and make sure you have a good diet. But does that really, one, educate somebody on what they're supposed to do? And two, is that going to motivate the patient out the door when they were just in a room for 5 minutes with a physician that says, eat better and exercise? So there's a large gap there which can be affected with potential rehabilitation interventions. And it's a motivation piece that we hopefully will be able to see. So with our diabetic activity levels, we'll see our control group. Our goal is pretty much 10,000 steps a day. With type 2 diabetes, they don't get the 10,000 steps, but they typically do walk more than somebody once they develop diabetes and if they develop diabetes with an ulcer. Or I'm sorry, once they develop neuropathy and neuropathy with an ulcer. So as we see the increase in disease process, the step counts, their activity levels get lower. Traditionally, doctors actually shunned weight-bearing activity because of the thought of the increased plantar pressure. So physicians, thankfully, this is starting to change, but in traditional sense, in classic recommendations, they said, don't walk too much. You're gonna put more pressure on your bottoms of your foot. You're gonna increase the plantar pressure. You're gonna increase the risk for ulcers. Thankfully, there's been research in this area which says we can actually now, hopefully, promote weight-bearing exercise and the safety of weight-bearing exercise in controlled environments with these specific individuals. And so what we see is if we can't just tell somebody who has diabetic neuropathy who's walking 2,000 steps a day, the next day go out and walk 10,000 steps. That may injure them. It's really a gradual progressive loading in controlled environments. So maybe they're walking 2,000 steps today, maybe they can walk 2,500 tomorrow. So small increases, controlled environments, and taking into that safety issues is kind of like the same idea of loading the plantar tissues, going to the gym and strength training. If you've never strength trained in your life, you're not going to go into a gym and lift 100 pounds. You're going to lift 10 pounds, and then progressively, if you keep going to the gym day after day, you can then lift 12 pounds and then 15 pounds. The same concept applies to the plantar tissues of the foot, and we call that the physical stress theory. Is if I provide a strong enough stimulus, but not strong enough to actually injure something, I can now potentially improve the health of the plantar tissues to then improve resilience, improve hypertrophy, and give it a better resistance to those high plantar pressures, and now increase the safety of the foot instead of decrease it. And then we know overprotection of the foot and limited walking can be harmful. If you don't use something, you lose it. If you're in a cast for a long period of time and you take off the cast, you'll notice that the muscles underneath have really atrophied. They've kind of shriveled down to nothing. So if they don't actually use their feet to walk, then they're going to lose that walking function even more so. And that can now be harmful. And then those who do have consistently high daily step counts really show no increase in that foot ulceration risk. So we know if we can train somebody to do something and we can keep it a consistent, motivated habit, then we know it's safe for them to do. And same idea with lifting in a gym or going out for a run. You don't run 10 miles on the first day, hopefully. You start out slowly and then you continue to go from there. So this is one of the biggest studies that was really the impetus for changes in the American Diabetes Guidelines and the International Diabetic Foot Working Group. Was a study by Miller et al. In 2013, who really compared weight-bearing exercise, so walking, squatting, lifting, to non-weight-bearing exercise where they were doing it lying down or sitting. And in a controlled environment, they noticed there's no additional ulceration risk. And each time they did exercise, they actually individualized it to a participant's ability level, an activity level. So these protocols were individualized per person. So this is really, the individualized part is really big into how I developed the final protocols or that we're testing now, is I wanna make sure that one, we can still stress somebody, but that stress is in an individualized, controlled way, and it's not applied the same to everybody. So thankfully, these are now guidelines that encourage weight-bearing exercise in those with diabetic neuropathy, and that as long as it's in a controlled environment and it's managed and monitored, those weight-bearing exercises are very beneficial. And it's not only beneficial in terms of the walking function, but beneficial for diet and exercise recommendations as well, which every physician tells you you have to pretty much be in a healthy diet and exercise. So from here, I thought of, well, motivation is something that a lot of people lack in terms of getting out the door to exercise. So not just people with diabetes or diabetic neuropathy. If it's snowing outside and it's 10 degrees and you want to get out and do exercise, you're probably going to get out and go for a run. No, because that's not motivating. Maybe me as a crazy person, I might, but that's not a motivating factor. So we thought of what is a potential motivating factor that's non-pharmacological, that can be used, can be potentially fun as an intervention, and we thought of biofeedback. So biofeedback is really something that you give somebody a targeted variable. So it can either be a sound, it could be a visual on a screen, and that is a target to hopefully increase their performance on that specific variable or other variables that you see. So it provokes a change in their motor behavior regarding that targeted variable. And then real-time gait biofeedback. So now I'm giving somebody these biofeedback signals as they're walking, and I'm targeting specific impairments. So I might be able to target that propulsion aspect. I might be able to target that increased plantar pressure and say, here's a screen, this is what you look at currently, here's a target, try to hit that target. And now they're thinking of it more like, oh, this is like a game. We actually have a virtual reality game that we developed for stroke, and it's a lot more encouraging than just telling somebody to go walk on a track. And then we have successfully used these same techniques to modulate propulsion in healthy able-bodied individuals and those with post-stroke hemiparesis. So those with post-stroke hemiparesis develop the same kind of propulsion deficit in their paretic limb that we are seeing in the diabetic group. So these interventions have been successfully used in that stroke participant. And now can we translate this into someone with diabetes as well? So this is some of our stroke data, and we can see that AJRF is actually the name for propulsion. We can see that the propulsion in the stroke group here had significantly increased with biofeedback. Something that I'm really interested in is really how the stiffness of the ankle joint itself modulates, because with diabetes, we lose kind of both a sensory and motor neuropathy component. So am I able to change how the stiffness of the joint reacts? And then the plantar flexor moment is something that relates to kind of like their power and their push off as well. So this is an intervention with our stroke group, and you'll see here on the screen, we have a visual target, and they're walking, and as they're walking, we're asking them to push back against the ground to hit that target on the screen. Here they have the white cursor that is moving real time as they're walking on the treadmill. They're trying to hit the target, and if they successfully hit the target, they hear a beep, and then they see it move past the screen. So now we're starting to turn these walking function components into, I can visually see it on the screen. Because a person with post-stroke hemiparesis, a person with diabetic neuropathy may not be able to feel their feet. They may not be able to proprioceptively feel that they're pushing off the ground harder, but they can see it on a screen. They can hear it with their ears. So it's another way to kind of teach them to walk with a different form. So then now we're looking at what does this propulsion aspect actually look like? So this was a set of pilot data I'd actually collected for the application for the K. And when we're looking at this is kind of the graph that comes out from the treadmill, and the treadmill has force plates in it. So we're looking at this top part of the graph, which is the propulsion of it. So we're looking at how they push off the ground backwards as they're taking a step forward to propulse them onto the next step. So I have this green line here for reference. So that is an able-bodied participant. That is their peak propulsion. Now for our next participant, this is somebody with diabetic neuropathy. We see that their peak propulsion is still fairly similar. However, now you're seeing large changes in the profile of how that actual propulsion impetus looks when they're actually walking. So they might be walking sideways, they might be walking with a limp, and I can look more into the data on this specific person. But this person also was more classified as a mildly neuropathic person. So they did have 28 years of diabetes. They were diagnosed with neuropathy by a physician. When you did a Semmes-Weinstein touch evaluation, they're evaluated to have diminished light touch and not necessarily loss of protective sensation. So when you look at the Semmes-Weinstein monofilaments, we're typically looking at quick doctor's office evaluation of a monofilament with a size of 5.07. And if they cannot feel at 5.07, that means they have lost their protective sensation. We did a little bit more involved evaluation with this person and kind of graded it based on an entire set of monofilaments. So we were able to grade them as having a diminished light touch sensation, but they still have that protective sensation to their foot. And then with our Michigan neuropathy screening instrument, they're just over the borderline to actually like refer them for neuropathy on that specific instrument. So taken together, this person would typically be classified as mild neuropathy. Again, the amplitude of the AGRF is not too much different, but the profile of their propulsion is very different. And then you take someone else with also mild neuropathy, and their profile is fairly similar. You don't see as much shakiness, but you see that they completely have lost the actual force to them pushing off the ground. So if you look at their amplitude, that is much, much lower, and that's still also a person diagnosed with mild neuropathy. We're not even getting into the moderate neuropathy or the severe neuropathy at this point, but you'll see that, yes, they have a long history of diabetes, and yes, they have neuropathy, but we're not even at the point where the neuropathy is considered moderate or severe, and we're still seeing deficits in these individuals. So with this pilot data, and pilot data was thankfully funded by our P30 mechanism that we have here, we're actually looking at baseline normalized propulsion, and we'll see that in general, our diabetic neuropathy group is very, very low compared to our healthy, able-bodied group. So this was able to give us that, yes, people have like maybe written about it in the literature, said it looks like they have reduced propulsion. Here's the actual data that show it. So what we did is we developed really 8 parameters for how can I affect that plantar pressure, how can I affect the propulsion aspect with 2 different types of biofeedback. So if you look at the graph in the corner, this is kind of a map of our plantar pressure system, and we're able to identify, for example, with the red peaks, where the areas of highest plantar pressures are in the foot. The one competing aspect we have with giving somebody either plantar pressure or propulsion feedback is if I ask somebody to push off the ground harder, I am likely also increasing the plantar pressures on the bottom of their foot. If I tell somebody to kind of lessen the plantar pressures on the bottom of their foot by looking at a screen, they're oftentimes not going to push off the ground as hard. So this is where the individualized protocol comes in, is we're going to need to find a balance between these 2 potentially competing factors to actually get somebody the best functional mobility without increasing their risk for injury. So this is the experimental procedures for the K. So a big part of it is that biofeedback component. So we're looking at each one of those biofeedbacks individually and seeing how does that affect my other mechanics that I'm walking with, and if I can find a best target using both of them to optimize the individual's gait. And the other piece of this is really a quality of life and clinical implications component. Is there something in a clinical exam that I can easily pick out that can be modified for in terms of rehab, or is there something that we can see that potentially predicts something? So we don't know quite yet how these clinical evaluations will relate to it, But the question is there something there, or is there something that a clinician might be able to do in an office is a 2-minute scan that could say, hey, maybe this person needs to be sent to a PT for rehab that would benefit them. So we're trying to look at this as a whole big picture overall. So this is the protocol for our biofeedback training. If we go back, we'll notice that we have like training sessions, and we're kind of training them over 18 minutes of walking in separate bouts. But the biggest piece of this is that we're also bringing them back 24 to 48 hours after they have kind of a 30-minute training session to say, did you remember what we taught you? Have you integrated some of these learning techniques, and has it carried over to the next day and 48 hours later to say, yes, I gave you a stimulus. You could do the stimulus when it was in front of you, but are you able to carry it over? So the next, I hope, stage of this is say, what's our best individualized protocol? And can we train somebody in a long-term setting to utilize this in the community as they continue to walk? So that's really the goal is, can I pick an individualized target, train somebody, and have them walk better in the community, go see their grandkids, go to the grocery store, go walk around the park, and have them walk better, walk with better function, reduce injury risk, and hopefully then better quality of life. So this is another piece of our propulsion biofeedback. Here, this is just an audible beep. And as you see in our laboratory, it's a pretty involved system for us to get. So here we're pretty much giving somebody propulsion based on the beep, not just a screen here, but we also have markers on them. We also typically have insoles on the shoes. We have EMG electrodes on as well. But there's also ways we can potentially take this directly into a clinic. So these are those 5 individuals and with diabetic neuropathy, and given the biofeedback, we are able to significantly increase the propulsion. What we're looking at now is how it also affects the plantar pressure, because we're in the pilot stages of that, and then hopefully starting our full data collection series come June is the target date. So plantar pressure side of this is really part of what could potentially cause injury. So we're looking at what are those areas of highest plantar pressures, and that can be seen with those really on the pink spots on the graph. And then we can actually give them a target that is very easy to see on, this might be a little jumbled, this might be a little jumbled, it might be hard to tell the colors, but if I can tell them, hey, bar graph, just look at one simple signal, this is where you want to be in terms of decreasing that pressure, we can easily see that pressure decrease as well. And then I guess secondly, we're also thinking of the body as a whole. So the Emory Sports Performance and Research Center is out at the Flowery Branch facility where the Falcons actually train. And I just recently started a collaboration with Greg Meyer at the Spark. And what he has developed, he is like multi-billion-dollar facility over there. It's phenomenal. And he works with professional athletes on a daily basis. And he really takes in the whole body as a whole to look at proper mechanics, and specifically things like anterior cruciate ligament prevention, injury prevention in the knee. So he's looking at the ankles, the knees, the hips, the trunk, the spine, and then giving somebody a stimulus that looks like pretty much a rectangle. And the goal of this rectangle and the individual doing the exercise is to keep the rectangle the same. And the rectangle will shift depending on if their knee bends one way, if their pelvis bends another way, if they have trunk lean, if their ankles are out of whack. So the shape of that, pretty much the rectangle will shift depending on what they see or what the system sees as a gait or a deficit in their movement. And the goal of the athlete is to be able to keep that rectangle the same. Now, this allows somebody to more, I would say, implicitly learn a motor pattern because they don't know exactly what they're looking at. So if I tell you, here's a graph on propulsion, I'm pushing off the ground, I know exactly what that variable is. If I show you the plantar pressure, I know exactly what that variable is, and it's more of an explicit learning style. So it's a little bit harder to internalize because I'm looking specifically at what I need to target. In terms of this type of mechanism, we're now looking at something that's pretty abstract, doesn't really make much sense, but when they get the correct movement pattern down, it stays at a rectangle and they know what they're supposed to do. So we're now collaborating with the Emory Spark to take some of this technology and move that into how can I get somebody to walk with the proper form in terms of diabetic neuropathy and optimize their mobility, limit their injury potential, and keep that as an implicit motor learning strategy. So we just started this collaboration with them to kind of take that same idea and now translate that into our clinical population as well. So I think that's a really cool technology they've developed, and that thankfully been able to get them on our side as well, on the clinical side. But now we see really big technology, lots of sensors in a lab. What can I do to actually put somebody in a clinic? What can I send somebody home with something? I don't have a lot of money in a PT clinic or in a physician's office. Is there something that I can potentially tell somebody to do or send them home with that can kind of provide the same thing? So what we've been testing is an insole shoe sensor. So these are fairly inexpensive sensors that go in the bottom of the shoe. There's only 3 sensors on each one of these insoles rather than the 100 plus that you saw on the plantar pressure system. But we have been successfully able to use something like this to actually affect the gait of individuals with diabetic neuropathy. So it is, these are what they look like. They're pretty much just small insoles that go in the shoes. They're 3 millimeters in height, so they're fairly thin, and they shouldn't put too much pressure on the foot, being only 3 millimeters, knowing that diabetics typically have very specific footwear they need to use. And we did validate this in our lab, so we know we're getting the data, we're getting the right information out of these sensors. And what it also has is it connects to your phone. It connects to a tablet. So I can have these in a patient's shoes, send them on a walk outside, and they could see everything on their own phone. I could send them home with the individual and they could practice this at home. And like I said, this system is actually fairly inexpensive, especially for someone like a physical therapy clinic to buy a set and then be able to lend out to patients. So what you see here is if we're looking at, this is actually a screen capture of what the application looks like on the phone. And we have our blue bar here, which is a biofeedback target I have set for that patient. So maybe a patient comes into a physical therapy clinic, you do some baseline testing, you set the target on their phone for, this is what I want you to walk with. And then specifically we set it on this sensor setting to the forefoot so they can push off the foot more. And it gives them that target, but it also gives them an audible beep. So even if it's in their pocket, they can hear the beep, they can see they can see, did I walk correctly? What it also does is maybe I have somebody that doesn't like audible beeps or wants a different type of stimulus. This can actually use the vibrate function on your phone too. So instead of hearing a beep, you can then feel it vibrate in your pocket if I'm pushing off the ground correctly. So it gives somebody a little bit more of a stimulus. So maybe they say, oh, I felt it on my leg, I'm doing the right thing. If it's in my pocket and it's vibrating. So it's again, now I'm into kind of the translational piece where I don't have all the big fancy equipment in the lab or research facility. This is more, we're now getting into the realm of, can I send somebody home with it? And I think the ultimate goal is taking whatever we learn in the research setting and being able to apply it to every single patient down the road via like a phone app or something, a sheet that the doctor is able to give you or something that hopefully affect the entire population rather than just the very specific people we see in the research setting. safety and foot protections, I really have to thank my clinical team. Because like I said, I came from a background of walking and running gait mechanics, and my clinical team has really been the impetus in being able to transition onto the clinical side. So I've done a lot of collaborations with our Grady physicians, Dr. Maya Feitman, who did our introduction, Dr. Marco Schechter, and Dr. Gabriel Santamarina as well. So our endocrinologists, our infectious disease specialists, and our foot and ankle surgeon, who I've actually known for a very long time, because he and my husband went to medical school together. So that actually came full circle. I'm like, this is the exact people I need. So the initial question I had of how did I get into this? And then finding somebody who really was the impetus of, well, now I know I can learn and I can be there in the clinics and see what's going on. When I understand the walking side, I understand the running side, it's the clinical piece that I was missing at first. So we want to make sure that with all of our participants we bring into the laboratory, we really do protect the safety and especially the bottom of the foot. So I make sure that all of our participants have had a foot examinations within the past 6 months to document ambulatory status. So we don't want to injure somebody or create an injury as we bring them in. They have to have physician clearance prior to participation. Usually not an issue because I recruit through my clinicians, so they're sending the patients to me. And then a big piece of this is that with diabetes and diabetic neuropathy, participants need to wear their own shoes. The shoes have to have a proper fit to them. They have to be cleared by a clinician for proper fit, because if we somehow bring somebody into a laboratory and put them in a standardized shoe and they can't feel their feet, well, now I'm potentially creating rubbing issues, or I'm creating size issues that they can't feel because they've lost some sensation on the bottom of their foot, and then potentially putting them at injury. And a lot of our biomechanical studies, we may actually have participants in a set of laboratory shoes so we can standardize it. Instead, we say, no, keep your own shoes, that's safe for you. And now we actually have a machine to measure their shoes and measure the stiffness of their shoes instead. So we can kind of quantify the types of shoes we have. And then a foot inspection. So we make sure before we start and after every couple experimental procedures, we're taking off their socks and shoes. We're looking at the bottom of the feet, seeing any and documenting any changes, taking pictures of the plantar aspect of the foot, and then also taking temperatures of the plantar aspect of the foot. Because we'll know that if we see a spike in temperature, usually over 4 degrees Fahrenheit, I think it was 2 to 2.2 degrees Celsius potentially, then you could be at an increased risk for ulcer on that specific spot. So we're really taking into account as if we're having somebody walk during these training protocols for 18 minutes, I'm making sure after every bout, I am really evaluating the safety of that foot and stopping if we need to not put anybody at an injury risk. And then wound documentation form, just in case they come in with wounds, we'll document it, send them home. Because we don't want to put somebody at a further injury risk. And then take-home points. We know that people with diabetic neuropathy really experience multifactorial walking impairments that affect quality of life. The two that I was focused on is the propulsion aspect, the plantar pressure aspect, but it's really a multifactorial problem. And it's not just those two pieces that are affected. It's every joint of the body that implicates you in walking. It is weight that you might see that might be a multifactorial really impairment to walking. And my goal is to hopefully develop something that is individualized to each person in front of me, that I can press a couple buttons and say, these are what you look like normally. This is what's going to be the best outcome for you. And again, now I'm looking at, those are the two factors I'm interested in, and they're also competing. So how do we maximize the efficiency of it? Because if I ask you to push off the ground more, you might have more plantar pressure that puts you at ulceration risk. If I ask you to decrease the plantar pressure, we might actually lose the propulsion and the functional mobility. So what's the best individualized target again? And then I really like to focus on non-pharmacological rehabilitation interventions, can be targeted to individual patient needs, and hopefully provide a motivating factor to actually get somebody to increase their physical activity overall. So a big piece of this is a lack of motivation. Can I turn this into a game? Can I get somebody excited about this? Can I get them walking again? And then the ultimate goal is, even if it's not this specific type of intervention that we're dealing with, is to develop some sort of intervention to pretty much break that cycle somewhere. So break that cycle of disability, break that negative feedback loop, and keep somebody walking, keep somebody healthy, and increase their quality of life. And questions? So these are my two boys. When I was writing the K, I actually submitted the first submission 2 weeks before he was born. The second submission, the resubmission, when he was 6 months old or so, and then I got the notice of award when I was pregnant with my second one. So they have been involved the whole time in terms of the K submission too. So, yeah. Questions?
So how do you, what do you guide them to do? Like if you didn't have this biofeedback, when it comes to like what their actual foot's doing to increase the propulsion, are they relying on other muscles to get that propulsion going?
Yeah, so what we do see with, unlike our stroke participants have kind of a neural deficit on their paretic limb that they kind of have to get other neurons firing to get them to walk better. Diabetic neuropathy is a little different, where it's actually more symmetrical instead of one leg versus the other. And they're also having a decrease in muscle strength as the nerves start to, atrophy. So it's really trying to create a symmetrical gait pattern and to maybe shift to a little bit more proximal musculature, hopefully, because diabetic neuropathy tends to go from like extremities in. So the tips of the fingers and the tips of the toes tend to be the worst at first, and then it works its way up. So you want to try to shift them to different gait strategies. And again, it might be individualized per person. The one thing we've seen in the literature and even in the people we've tested is that everyone's gait pattern seems to be very, very different. There's not one uniform kind of deficit that we see is, oh, I have more ankle flexion or more knee flexion or more hip flexion. The way they accomplish their walking is very different. So it's going to be more of an individualized approach to get them to what they need to do. Yep.
I have a question.
Yeah.
How did your participants feel after the intervention?
So, what's actually good is we had a survey after we actually did this, and we had them evaluate the insole. We had them evaluate if they would wear it again, if they would do the intervention again. And the biggest piece I got out of this, because we also used those insoles in an entire group of stroke participants as well, and we've used the biofeedback in an entire group of stroke participants. The biggest thing is that I think overall, they said that it was fun. It was kind of a motivating factor. It gave them a target to hit, kind of like a game, and you try to score points for a game. It was the motivation piece that I think was a big component to it, that hopefully will get them to walk. And we know that those insoles that we had, we actually didn't cause any discomfort according to the surveys that we gave them. So that was positive. They said they'd be willing to use it again, and it was the motivation piece that was key. So if we can motivate somebody to get out the door and start walking, that's step one. That really is step one.
So I have another question about the SPARK study. So for that, it was like classes that they had on, and then like there was like feedback there, or it was like outside?
So what they use for the athletes is actually an augmented virtual reality headset. And we know that might not be great for our either diabetic neuropathy group or our stroke cohort. just because of the way the cognitive processing works. So we are trying to develop it on more of a screen in front of them rather than the virtual reality headset. But the Spark does use the virtual reality headset because they like to put their athletes in like actual game type situations, like they're on the field or they're on a basketball court, for example. So the technology they have for the athletes is developed. Is it the best for these types of clinical populations? Maybe not, but that might be something to look into. So it's there, it can be modified, but is it the best for this population?
Yeah, that's what I was thinking. I was like, I even sometimes like virtual reality, I'm like, I can't, I get dizzy and I don't have stroke or diabetes, so it's like.
Yeah, so the goal is to develop it without the virtual reality component first, and then, because the cognitive processing is very different.
Is this intervention more appropriate for early on in the disease course, like before the neuropathy develops?
I don't know if we're at the point of answering that question quite yet. It could potentially be beneficial, really before the neuropathy starts, because if I can say, keep walking with this form and they learn ingrained motor patterns, then hopefully, we now increase their physical activity, so hopefully they don't develop the neuropathy, or if they do, they can now have the motor pattern ingrained so that they continue it throughout instead of it being lost. So I think there's a great potential for it. We haven't exactly looked at it, but what we're doing is being able to, now with the participants we have, grade the severity of neuropathy or non-neuropathy that they have, so that way we can say it either works better for this mild or none or severe. So we're looking into the severity component of it, but it's probably very beneficial is if I can get somebody before they develop gait problems, make sure they learn and have a cognizant motor learning pattern of it, then maybe hopefully we don't run into the problems in the future.
How is the cost of implementation? Could it be even implemented in other cities like Africa?
Yeah, I mean, I think that's yet to be seen. It's taking technology and then trying to figure out how to use it at the moment. So yeah, I think we'll have to see how to translate it more into a clinical.
How is the cost?
I'm sorry?
Is it cost effective? Did you check the cost?
Yes, so for example, the insoles that we had that are clinically applicable are fairly inexpensive for a clinical setting. So I think an entire size range of insoles, from like the smallest women's size to the largest men's size, was like $10,000 for the overall set, but it can be used in a clinic setting for years. So it is a small piece of, it's an investment on that side, but it can be used for patients over the years compared to our research equipment, which is hundreds of thousands of dollars. So it's very different in terms of comparison wise, and can we use some of these other technologies, or can I develop something that's just on a tablet app or a phone app that's free for everybody to use, using the camera on somebody's cell phone. So that's another avenue to potentially go down. But I'm also not an engineer, so I have no idea how to develop some of those technologies. But that's definitely something I would love to look at is, can I get an engineer and say, these are the factors we want to target. Can you do it with the camera on the cell phone? Yeah. Do we have any questions in chat or, okay, we're good. All right.
Or if there's anyone online, you can speak up. If you don't, put it in chat.
I just had a quick comment. Is that okay?
Yes.
So I've had lots of discussions with Nicole about this project, but this presentation still helped with some of that synthesizing and stepping back. So I think your point about this being a really nice preventative strategy is awesome. I think that'll have a lot of impact, but it might be good to hear from the clinicians or get feedback on how would we go about testing that, right? Like if someone's very early and we're using this to retrain their movement patterns, so we prevent the ulceration and prevent the symptoms from worsening, what would be the best way to track outcomes for a preventative strategy? You know what I mean? Because I think that would have a lot of impact beyond also just restoring the movement patterns. But great presentation. Thank you.
Thank you. Yeah, that's a very long perspective study that we would need to hash out all the details and figure out how it works. So, yep.